Well, good morning, everyone. On behalf of MSF, we thank the workshop organizers for inviting us to give this presentation with regard to our perspectives on treatment as prevention. The outline is first. Briefly, we say something about how we stand with regard to HIV and treatment as prevention. We will speak then a little more about two projects which are advancing, which are ready to be implemented. In fact, the KwaZulu-Natal project in South Africa and Shishilweni project, which is in a quite advanced stage of starting. Then we'll speak briefly about the tools, and then second and last about the strategies, especially the community strategies. Well, MSF, we are currently involved in HIV care and treatment for over 220,000 patients. As you know, we have been helping in initiating and supporting HIV care and treatment since more than 10 years. We do this mainly in sub-Saharan Africa. But what we want to say is that, we speak about treatment as prevention and, of course, based on earlier access to ARV treatment. But we must admit that even within the projects where we are supporting HIV services, that even there we have projects where we are still initiating people on ARV treatment according to clinical staging and even according to CD4 levels, which are still below the current criteria for ARV treatment eligibility. So even us, together with our partners, we have in certain contexts difficulties to implement the WHO recommendations. Well, something briefly about the MSF strategic framework with regard to HIV. We have revised it in May 2010, and there we recognize that HIV/AIDS remains an exceptional medical crisis requiring that exceptional response. We confirm our long-term commitment, even as humanitarian medical organization with, let's say, short-term and mid-term commitments. We want to continue to focus primarily first on reducing mortality and improving long-term survival. We see through our advocacy that we have a role to play in countering the retreat, which we are all confronted with. But also, besides our focus on reducing mortality and improving survival, we are prepared also to become more and more involved in reversing the epidemic through prevention strategies like treatment as prevention. How do we see our added value on treatment as prevention? Well, of course, we are here, we give this presentation here, I give this presentation here between several presenters who speak about scientific evidence. We see our role more in piloting treatment as prevention and by doing that, demonstrating whether it's feasible and acceptable in real world conditions. And that in complementarity, of course, to the randomized control trials, which are focusing on proof of concept and efficacy. Through our advocacy, we are, of course, we are always reminding, and we are reminding about, of course, the concerns of everyone on the current funding retreat, and so the risk of losing capacity to continue to sustain that scaling up for HIV care and treatment, and on the top of it to lose this momentum, to miss this momentum on doing more, so that we can also have through, for example, treatment as prevention, impact on HIV incidence. We see in the context where we work, and I think there is a risk that we are going to have a more and more a disconnect between, let's say, the aspirational projects, which are projects not only working on mortality, decreasing mortality and increased survival, but also working on decreasing of incidence via, for example, treatment as prevention and even test and treat. And then the other projects where we have, in fact, where we have to focus, we have no other option than to focus on essential service delivery. And essential service delivery, for example, at least making sure that people have access to treatment according to CD4 below 200, and of course, according, and as much as we can according to the CD4 levels below 350. In many contexts, we are confronted now with governments who really would like to implement what has implement what we see coming out as scientific evidence, but then they have to retreat on their commitments, on their ambitions, and so efforts are stalled due to funding. And of course, we see ourselves as an organization which is helping to get things done, but also often we are in a situation where we have then to review where we cannot continue with the ambition we have, for example, with regard to treatment as prevention. Yesterday was shown this slide about projects where either we plan to start or where we started or planning to start treatment as prevention. As you can see, in fact, we are just about to start, and the first project where we have started is in a district in KwaZulu-Natal, and it's especially in relation to implementing PMCB+. Given the Malawi has chosen openly, so in terms of policy, to implement PMCB+, and also there we have two projects where we are trying to pilot it to show, to learn from the lessons on acceptability and feasibility. You see there are a lot of other projects where we are planning to start. Those projects are either in an advanced stage of negotiation or we are still in preliminary stage of discussion. So the areas where we are working on treatment as prevention, as I said, on PMCB+. Then we have a few projects where we are proposing to see whether we can offer earlier access to treatment according to a threshold, the CD4 threshold. And then there are projects where we are looking at, can we indeed implement test and treat? And then first, of course, implement, work with serodiscordant couples, but we can also look at other groups, the high-risk groups. KwaZulu-Natal, reducing HIV and TB incidence. I understand that last year there was a presentation here. We are setting up this project in a district of a population of about 110,000 people. You see the prevalence levels, so it's a very high prevalence level, with also highly affected by TB and even an increasing problem of MDR TB. The areas where we work, it's rural as well as semi-urban. The objectives, it's a project, of course, which is aiming at, to reduce HIV and TB incidence, morbidity, and mortality. The secondary objective is definitely to demonstrate the feasibility and the acceptability of large-scale testing, retesting, treatment, and prevention strategies. It consists of, from one side, increase the testing, the linkage, the entry, and the retention in care. From the other side also, it aims to integrate it. It wants to implement also combination prevention strategies with regard to HIV and TB. The earlier ARV treatment administration protocol, CD4 below 500. Initially, the project was also planning to use a viral load threshold, but that has been cancelled. And then there are several groups, of course, for which the project wants to put people on treatment irrespective of CD4 count. Pregnant women, by implementing the PMC option B, HIV positive individuals in serodiscordant couples, people with active HIV infected people with active tuberculosis. That's particular to South Africa, but in South Africa it's co-infected people are not automatically, are still, HIV TB co-infected people are still put on treatment when they have a CD4 below 350. So this project is also proposed to do that for all HIV TB co-infected patients, regardless of their CD4 count. Where is the project now? The project is very ambitious, and it's in fact, here in this context, MSF started from scratch, and so it took some time to get ethical approval from the relevant authorities, and then to get started. And of course, what we realize as an organization is that, you want to introduce something new, treatment as prevention, and combining that with other prevention strategies. But of course, the available HIV services need often support. And so that's why, in fact, we had to invest also in supporting HIV services in clinics and hospitals, and then while starting to work at the level of the community. The targets of the project are very much linked to the targets of the national program for South Africa. It's considered as an enhancement. So I'm not going to go over the targets, but the targets are more ambitious than the National Strategic Plan of South Africa. And hopefully it can show the way forward for later on when the National Strategic Plan is being reviewed. What has definitely taken off is, well, outreach services, and then one example is here, for example, mobile one-stop services offering HIV counseling and testing, CD4 and TB testing, and with a quite good uptake among young people and especially women. And it's also interesting to note that, well, 1/3 of those people have indeed a CD4 below 350, while the others are above. The other project, the Sylvania region, in Swaziland, it's there we are proposing to, well, MSF is working there already since several years, helping the Ministry of Health and working also with other actors in decentralizing HIV and TB services. It's a context with a similar level of prevalence for HIV and TB as KwaZulu-Natal. It's now we are proposing now, so besides, well, after having decentralized with task shifting together with the Ministry of Health, now also really to work on trying to contribute to reducing HIV and TB mortality, morbidity and incidence by integrating treatment as prevention and in particular test and treat. It consists of, from one side, reinforcing the Cascade, secondly, piloting PMS-TB Plus in one zone area of the region, still to be defined, we are still discussing that, and then gradually also in that same zone or area, introducing test and treat for infected adults. We'll start with serodiscordant couples, of course, and then we'll see how we can expand beyond that. But that's planned for 2013. So we're talking here about implementing a program in a phased way. So reinforcement of the Cascade, PMS-TB Plus, and then later on, test and treat. The reality in this context is that we still have a huge testing gaps in adults. So less than 20% get annually tested, and it's probably even less because among the testing, there are people also who come for retesting. But so that's the reality in this context. We have, in terms of ARV treatment, which is highly decentralized and also mainly based on nurse initiation and management of ART, we are close to universal access in this context. And we have relatively good treatment retention. We would not say it's optimal, it can still be improved, but it's relatively okay. The PMT Cascade analysis shows that it's also relatively good, but I'm not going to enter in detail. There are certainly areas which can be improved, and, but overall we have a quite good basis for working on PMS-TB Plus. The piloting of PMS-TB Plus for all, well, for HIV positive pregnant women in this health zone, what we show here is that, well, when you start to plan for that, it's useful to look at, well, what does it mean in terms of numbers of women we can anticipate, we have to anticipate to be put on ARV treatment according to such a PMS-TB Plus strategy, in addition to the women who are eligible for ARV treatment for their own health. And that's of course important to do for resource planning. And we have to take into account, it's not only that we put women every year, a certain number of women on treatment, but also we have to retain them, and we have to take into account also, well, the retention on an annual basis. So behind this, there's quite some calculation behind this, but we have been doing quite some projections to determine for ourselves what does it mean in terms of resources required. The same thing is for test and treat, which we would do 1 year later, and which has to take into account also, of course, meanwhile, the pregnant women who have been put on treatment according to the PMS-TB Plus strategy. So, summarized with regard to our MSF perspective on treatment as prevention, what we think is important is, well, in terms of tools, that we need to introduce decentralized access to viral load, laboratory-based using DBS, and later on we will look also, of course, at the possibilities for point-of-care viral load. We need to have affordable, optimized first-line ARV treatment regimen, and at present we believe that tenofovir 3TC efavirenz is the right regimen, but it's still expensive, it remains expensive. And of course we need adapted data collection to enable monitoring and evaluation and operational research. In terms of strategies, treatment as prevention definitely requires social research and communication on perception and acceptance. Community-based testing is really important, so out of health facilities, community-based testing, community ART delivery and follow-up, and then we have to look also at, well, where we have to reinforce capacity for treatment education and patient support. The strategies to reinforce the cascade, what we, at the level of testing, definitely supporting, reinforcing provider initiation of testing and counseling, but also community home-based testing and counseling. At the level of, well, eligibility, point of care CD4, in which we are heavily involved to introduce it, linkage into ART and pre-ART care. And then when we look at retention, ARV treatment, self-management outside the health facilities, and meanwhile introducing viral load monitoring of treatment adherence and response. Still with regard to viral load and CD4 point of care, we are starting a comparative research whereby we are going to look at, well, feasibility and cost effectiveness of decentralized access to viral load and CD4 point of care testing versus a district level laboratory-based setting for CD4 viral load and early infant diagnosis. We are going to do this across 5 countries in 8 sites. And we hope to provide recommendations on best devices and best models. We are speaking here about a 3-year project, and we got also financing for that from Untitled. And it will be followed with a more detailed analysis and including market assessment, price transparency, etc. Speaking about ARV treatment community, well, we have published already on on a few experiences with regard to organizing more and more ARV treatment follow-up and management at community level. And some of you might have read the publication regarding the experience in Mozambique. So we are now documenting more our community-based strategies. And in fact, what we want to highlight here is that finally, in all those community-based models, we can clearly demonstrate that cumulative retention is much higher. It's often much higher than what we have when people are being followed up only through health facilities. And so we definitely believe that's one of the ways forward to reinforce the cascade, but also to make treatment as prevention happening, to support the implementation of treatment as prevention. Outstanding questions we remain with as well, that one ARV treatment regimen that fits for all, it's still too expensive. Other question as well, we welcome of course the guideline about community couple testing and ARV treatment for serodiscordant couples, but we have to look at how we can adapt definitions and strategies to reach those couples. And then we have to, and of course we remain still with the lacking evidence for individual benefit for ARV treatment initiation when CD4 is more than 500. We have also questions about monitoring HIV incidence. We as an organization, we don't see it in our capacity and expertise to implement incidence studies. So well, thanks for the attention. That's it.